Yeah, thank you, Dr. Rajesh. It was, thank you for the invitation and the opportunity. And good evening, everyone. I'm Dr. Harshvardhan from Navi Mumbai. Today I'm going to speak on corneal neurotization, our experience in the last 5 to 6 years that we've been doing this. No financial disclosures. So this is one of our cases. It's a cornea sparing evisceration, and 10 years later the cornea is still clear in spite of the evisceration. So how does that happen? And that's because of the nerves which are still intact. So epithelialization, transparency, all are affected by the presence of corneal nerves. We all know these causes of neurotrophic keratopathy may be infectious, inflammatory, traumatic, neoplastic. And in diabetes especially, it not only causes dry eye because it affects the nerves directly, but it also affects the epithelial growth factor, which affects the epithelialization. While in herpes, it's mainly the viral proliferation that affects, not the inflammation. And post surgeries like PRK, LASIK, radial keratotomy, we have neurotrophism. And confocal microscopy plays a important role in monitoring the progress of the treatment as well as the disease. So there are various techniques of or neurotization of the cornea. Either you can use the supraorbital or supratrochlear nerve directly and invert it onto the cornea of the same side or the opposite side. But it's a fairly destructive process. It needs a large coronal incision on the forehead. But if you use the sural nerve, which is the medial cutaneous branch of the sural nerve from the foot, you can have better neurotization without creating too much of dissection. And it can either be used on the contralateral side, and if you have ipsilateral sensations prevailing, then you can use it on the same side as well. So this is the direct technique which was earlier used, and this is the sural nerve being used. We'll come to the case, that case-based illustration. This is our case where patient presented with herpes simplex of one side, and she had perforation as well, and there was neurotrophic keratopathy, and the corneal sensations were almost zero, and the vision was maybe perception to light. And we performed a sural nerve transplant to the ipsilateral side, and this is the way we procured the nerve, which is this is the medial cutaneous branch of the sural nerve from the foot, and this is a surgery where this branch of the nerve is then used to neurotize the cornea. It is connected to the supraorbital nerve in an end-to-side anastomosis. The importance being to remove the nerve sheath properly and to connect the nerve fibers so that you can have the neurotrophic growth factors reaching the cornea. And then the fascicles are made, and they are then taken under the conjunctiva, and covering all the 4 quadrants is important, and then creating subscleral tunnels to reach the cornea. And then finally the conjunctiva is sutured as well as the wound on the skin. So this is how the pre-operative picture was, and then later, 8 weeks later, we found cornea quite clear. The epithelial defect was no longer there, and the nerves had also grown on OCT as well as on confocal. So this is pre-op. This is 4 weeks later, the epithelial defect healing well, and 8 weeks later, it is completely healed. And this compares well with other studies also. The vision improved from light perception to 6/18 after 3 months, and the aesthesiometry scores also improved to around 50 from 0. And the various studies also compare well in the literature. It's not a very new surgery since 2009, and in terms of nerve growth, epithelial defect healing, sensation recovery, vision recovery, it compares well with our study. We can also use immunostaining to look at the nerves, as well as gene marker studies to find out, to prove the presence of nerves growing into the cornea. Basically, the nerves affect the stem cell functions of the epithelium. That is why we get epithelial defects. So this is a study which shows that how the progenitor stem cells are dependent on innervation for them to grow. So it also affects neovascularization. So whenever there is loss of sensation, you will have neovascularization. This study shows how VEGF-A and VEGF-B play a role. VEGF-A is mainly for neovascularization and VEGF-B plays a role in neoneurization. So once you have the nerves growing, the vascularization automatically reduces. This was a case report which we published in BMJ, where we had shown that how the vascularization of the cornea had reduced significantly after we did the neurotization procedure. This is one of our first cases, which was probably the first in the region or the country maybe. And these are some of the cases which he had done, patients like farmers seeing after 5 years because the cornea cleared up after neurotization. And this was our IC at World Congress in Mexico. And these are the advances. Now we know there is a nerve growth factor available, cinegermin, which also has the same effect. However, it does not improve the sensations. It only helps in healing the epithelial defect. And it is quite expensive. It's like almost 8 lakh rupees in Indian rupees. While the neurotization procedure is more like a direct or a definitive treatment as compared to the nerve growth factor. Pediatric neurotization also we have done. The difference is that we have specific landmarks for the sural nerve in the pediatric foot. The fascicles have to be properly placed in the sclerocorneal tunnels for them to grow. Thirdly, the assessment has to be done objectively, like decrease in vascularization, because the children are not that cooperative. And there is something called as magnetoencephalography, where we check EEG impulses, and we find that the impulses are taken up by an area of the frontal part, which corresponds to the supraorbital nerve. So it's like stimulating the cornea, but the sensations are picked up as if they are coming from the supraorbital area of the forehead, because it is connected to that nerve. So these are the magnetoencephalography images. Okay, Karuna. How do you, okay. And this is a nerve exoguard. I'll just finish quickly. Exoguard is a extracellular matrix which is available nowadays, which allows the nerve to grow through it. So it protects the sural nerve that has been placed under the skin of the forehead. And we also do endoscopic neurotization, where we get better visualization and faster surgery time to locate the nerve as it passes from one side to the other. And we have also tried robotic neurotization with the Da Vinci robot we have at one of our hospitals. And we found it to be improving in terms of tremor cancellation, precision, magnification, and lesser inflammation. But it of course has cost and time issues. So in conclusion, good recovery of corneal sensations, vision, and corneal integrity. It compares well with our 5-year experience since 2015, almost 7 years now. The mechanism of corneal healing is stimulation of limbal stem cells. Neurotization and neoneurization are affected by growth factors, and VEGF-B plays a major role. We have evidence on confocal, immunological, and genetic, and neurotization also inhibits vascularization, and the recent advances include pediatric neurotization, extracellular matrix protector, endoscopic and robotic surgeries. Thank you very much, and thank you for the patient listening.
Thank you, Dr. Harshvardhan. It was fantastic. Very nice study and very nice presentation.
Thank you.
Thank you very much.
In how many patients did you perform this corneal neurotization?
So we have now almost done around 25 cases. And it's been more like a multi-centric. We have visited various hospitals and done, and in our area we've done almost 11, and the remaining in various centers across the world. So we are gathering those data as follow-ups, and then maybe we'll come out with the results at various centers. So we have found that mainly the trauma cases, the tumor cases, the unilateral cases, herpetic cases, they do very well. The general cases like diabetes also do well. But congenital anesthesias and all, we have done one pediatric case with a DALC procedure in that. They have moderate results. I mean, although the epithelium heals, we are not sure about the sensations. So that's how we have found, and we'll, I think, come out with some data very soon.
Thank you. Very nice.
What's the gap, isolating the sural nerve and then doing it?
Same day. I mean, we have a plastic surgeon doing the foot thing, and we have already started dissecting the forehead. So that's how it goes. Sometimes if the plastic surgeon is not available, we do it ourselves also. So it's like a very superficial nerve on the medial side. It can easily be, and it doesn't have any effect on the final, on the foot also. I mean, you don't have foot ulcers or anything after that, because there is a lot of cross connection between the nerves in the foot, so they take over.
Thank you.